If you are a physician associate new to orthopedics, watch this video before seeing your first ankle fracture consults. I'm a board certified orthopedic surgeon, but I remember my intern year seeing these ankles for the first time. I was just completely lost. So you don't have that problem. I made this video as a quick breakdown to get a quick overview. I would use this video as a jumping off point to reading more in-depth sources like ortho bullets. But let's get into ankle fractures. Here are the basics of ankle fractures. At its most basic form, ankles have three malleoli. The lateral malleolus off the distal fibula, the medial malleolus off the distal tibia, and the posterior malleolus. As a general rule, if two structures are injured, it's an unstable fracture and generally needs surgery. So that's the basic form, but there's more because there's soft tissue that is very important, namely the ligaments. And you can't see those on x-ray, but the x-rays leave clues. So you have to understand three major ligaments. The first are these ligaments that attach to the distal fibula. These are the ones that get implicated in low ankle sprains. The next one are the ligaments that attach the tibia to the fibula. We call that the syndesmosis. Syndesmosis. You can think of the posterior malleolus as an attachment site for the syndesmosis. And the last one is the deltoid ligament off the medial malleolus. If you injure a ligament and a bone, that counts as two structures that are injured, and we're going to get into that a little bit later. So let's start with the most commonly fractured bone in the ankle, which is the distal fibula. Now that can fracture in one of three most common places. One is the tip of the distal fibula, right where these ligaments attached. Second is this sort of oblique fracture at the level of the syndesmosis. And third is above the level of the syndesmosis. Now some white guy named Weber came up with a pretty usable classification system called the Weber classification system. This first fracture we call a Weber A, distal fibular fracture. The second one at the level of the syndesmosis we call a Weber B, distal fibular fracture. And the third, above the syndesmosis, we call a Weber C. Let's move on to the next most common fracture we're going to see, and that is the medial side. So the most common medial malleolus fracture is this oblique fracture. We don't really have a classification for this, but you do need to know a couple variants. One is the vertical medial malleolus fracture. We just call it a vertical fracture. And the third is sort of an avulsion type fracture similar to the Weber A, where it's just off where those deltoid ligament fibers attach. Now, even if there is not a fracture of this medial side, you can still have a significant injury because a deltoid ligament can be injured. And you can't see that on x-rays, but the x-rays leave clues, namely at this joint space. So this view, the mortise view, refers to this mortise joint, this joint where the talus articulates with the tibia and the fibula. So this is the talus, and this joint space should be equidistant all the way around. If you got to measure a ruler and measure this distance, should be the same all the way around. If you injure this deltoid, many times everything will shift, especially if you have an injury on this other side. So say you have a tibia like this, you have some sort of injury to the fibula, and you might have sometimes quite a subtle change in this mortise. Let me draw this a little bit better. So if you notice, this distance is much smaller than this distance. And this space we call medial clear space widening. Medial clear space. Because this mortise, we refer to this space as a medial clear space, this as the lateral clear space, and this as a superior clear space. But what you want to look for in every ankle fracture is a subtle widening of the medial clear space, because that implies a deltoid ligament injury. Next thing you will see is a posterior malleolus injury. And again, this can be fractured in different degrees. You can have a little shell fracture, you can have a more substantial fracture, you can have a large fracture. There are classifications for this, and historically we use a 25% rule. So if this involved more than 25% of this distance, you would fix it. Now that is a rather antiquated way of thinking about this. We actually don't consider posterior malleus in that way anymore. Now we get a CT scan. It gives us a better view of it. So if you have a posterior malleolus fracture, it's a good idea to get a CT, and it'll look something like this. So the tibia looks something like this on an axial cut. The fibula looks something like this. This is anterior. This is posterior. This is lateral. And what you will see is possibly a shell type posterior malleolus fracture. You might have a more substantial fracture. You might have one that extends over here. You might have one that goes all the way across. Either way, the CT scan is a much better way to evaluate the posterior malleolus fracture to see if it needs some sort of fixation. Moving on to the next ligament, which is this syndesmosis. It's probably the most challenging ligament to assess when looking at x-rays alone. And the reason is this space, which is a space between the tibia and the fibula, so therefore we call it the tibiofibular clear space. This clear space changes very much depending on the rotation of the x-ray. Now in very obvious scenarios, say we have a scenario in which we have a fracture, a high fibular fracture, and the other end of the fibula is way over here like this. Well, this is obviously widening of that tibiofibular clear space and obvious syndesmotic disruption. But it's not always that obvious. What if it looks rather normal? Well, there are ways we can reveal an injury, and those are different kinds of stress testing. The original one would be a external rotation stress test, where you literally get the patient's ankle and you externally rotate it under x-rays, and that will show widening of this or even widening of this medial clear space. The second way, which is slightly less painful, is called a gravity stress test, where you just have the patient just let gravity turn the ankle off to the side and you take an x-ray, and that can reveal widening. A simple weight-bearing view can reveal syndesmotic instability. And finally, comparing the contralateral ankle. So get x-rays of both ankles and see if the injured one is wider than the non-injured one. And I can't end this talk without talking about dislocations of the ankle. The talus should always be centered under the tibia in both views. If this dislocates, and in the case of this lateral view, it usually dislocates posteriorly. So it's going to look something like this, and often causes this posterior malfracture. Well, this has to be reduced. You cannot send the patient home with it dislocated, or you'll never get it back in place without some massive surgery. So this has to be reduced. And on this view that I drew here, this would be considered an ankle dislocation because the middle of the tibia is no longer lined up with the middle of the talus. If you are managing these fractures in the emergency room, what are the basic steps? Well, first, you want to do a skin check. Is this an open fracture? You want to check for swelling. A good way to test is if the skin wrinkles, it's mild swelling. If you cannot wrinkle the skin and it's very tense and tight, it's severe swelling. This has implications for whether or not the surgeon will do surgery right away or not. 3, everyone gets neurovascular checks. You need to check the dorsalis pedis pulse and make sure their sensation is grossly intact. And when it comes time to stabilize them, stabilization, when in doubt, you should put them in a splint, namely a posterior splint with stirrups. Once in a while, if there's a very stable lateral malfracture, I will send them out in just a boot. Weight bearing is tolerated, but you need to have verification that it is a stable fracture, because I have seen unstable fractures sent out in just a boot, which is inadequate. So we're going to look at some x-rays to see these in action. So let's look at some x-rays. Here on the right, we have an AP of a skeletally mature right ankle, and it is showing this fibular fracture. And if you remember our Weber classification, this is a Weber A distal fracture. You should also be looking at this mortise. Not a great mortise view, it's actually an AP, but don't see any significant medial clear space widening. I would say the mortise is intact, and I would say this syndesmosis or the tibiofibular clear space is intact. Here on the lateral view, we don't see any posterior malfragments. We see that the joint is well reduced. There are no other fractures on this view. Look at our next case. This is an AP and lateral of a skeletally mature ankle. It's actually a mortise in a lateral view of a skeletally mature ankle showing this fibular fracture. And if you remember our Weber classification, this would be a Weber B because it's at the level of the syndesmosis. Don't see any significant widening at the syndesmosis. This mortise looks the same all the way around. So I would say the mortise is intact. The ankle is reduced on both planes. Next case, again, we have a mortise in a lateral of a skeletally mature ankle showing this high fibular fracture, what we call Weber C fibular fracture. And if you look at the mortise, I can appreciate a subtle widening. If you would measure this, if it's about the size of two of those dots, well, I would say I could fit 1, 2, 3 dots in this medial. So I would say this is a widening of the medial clear space, which suggests a deltoid ligament disruption. Here's a lateral view. It's well reduced. I don't see any fracture of the calcaneus or the talus. Here's a mortise and lateral of a skeletally mature ankle, seeing Weber B fracture of the distal fibula and a transverse medial malfracture. The ankle is reduced on both planes. I don't see a posterior malleolus fragment. Here's a mortise and lateral of a skeletally mature ankle, showing a Weber B distal fibular fracture. Interestingly, there is either an old or a healing higher fibular fracture, or it could be another unusual bone lesion. We also see this medial malleolus fracture, and this is that vertical medial malleolus variant. We can actually see some medial clear space widening, but that's associated with the displacement of this medial malleolus. I don't see any posterior malleolus fragment. I don't see any other fracture. So here is an AP and a lateral of a skeletally mature ankle showing a Weber B distal fibular fracture, transverse short oblique medial malleolus fracture, and a posterior malleolus fracture. So this is a tri-malleolar ankle fracture. The joint is reduced on both planes, and there's some definite displacement laterally. And finally, here we have call this an AP and a lateral of a skeletally mature ankle showing a Weber C distal fibular fracture. See a transverse medial malleolus fracture. In the lateral plane, we see a posterior dislocation of the tibial talar joint. Here is a very large fragment of the posterior malleolus. So this is a very unstable tri-malleolar ankle fracture. Interestingly, there is also a screw here. So it looks like this person had a proximal fifth metatarsal fracture that was treated surgically. This is the same case. They got a CT scan to evaluate this posterior malleolus fracture, and you see it's quite a large fragment. This almost certainly is going to need some sort of fixation, maybe even a plate. If you made it this far, thanks for watching this video. I hope it was helpful. Please put in the comments anything else you want me to break down, any other problems you might be having. Good luck.